So we're here with Dr. Michael Amini, shoulder and elbow surgeon, orthopedic surgeon. And we thought we would take a few minutes exploring a topic that maybe doesn't get as much attention as hip and knee replacement, but is as vitally as important as those other two topics. And Dr. Amini is joining us from Phoenix here teaching a course on shoulder replacement. So I thought there was no better expert to give us maybe a clear understanding of what's happening as of today in shoulder replacement. So we were talking a little bit earlier. Tell us about the types of people who need shoulder replacement nowadays.
Yeah, I think there's largely three main groups. There's the person who has shoulder arthritis, the cartilage is worn down, they have bone-on-bone arthritis just like any other joint, and they get what is typically a standard shoulder replacement. Not to say the standard is less, but the conventional ball and socket replacement. The group that has really grown over the last 15 years or so are the people who have massive rotator cuff tears, or even rotator cuff tears associated with arthritis as well. Those people are getting a reverse shoulder replacement, and that's really designed for that very specific person to give them the pain relief of a joint replacement, but also actually help them restore function. So they would come into the office unable to raise their arm, they would do this. Mm-hmm. And then we do the reverse, and they can actually restore the ability to raise their arm and get up to at least a pretty modest or even a high level of function after that replacement.
Okay.
And the third group is more of the salvage type situations where we have fractures that we don't think would heal if we put them back together with standard plates and screws, or we have failed joint replacements done years or decades ago that need to be replaced. Mm-hmm. And those are kind of the three large groups of how those break out.
Okay. You know, if we step back and we talk about the typical patient with shoulder pain, mm-hmm. and we see this all the time in our office because they got a bad hip, they're older, right? Their joints are well used by the time they see us. And
sure.
So they got a bad hip or they got a bad knee, and they say, my shoulder hurts.
Yeah.
They're often talking about their rotator cuff.
Mm-hmm.
Tell me the difference between rotator cuff issues and shoulder arthritis, which would warrant a shoulder replacement.
Yeah, rotator cuff, I think, gets a lot of people's attention because it's far more common. And then there are also people whose tears are so large they're not repairable. So people are often fearful that they get to that stage where nothing can be done. There still is always something that can be done. It just changes based on how severe the problem is. So the rotator cuff tears, they are often a wear and tear process. Sometimes they can finally happen in an instant, but they're often a wear and tear process that occurs over years and decades of somebody's life. The arthritic shoulder, instead of wearing down the tendons, wears down the cartilage, the smooth surface of the ball and the socket,
okay.
And they end up with bone-on-bone arthritis.
And so it's a completely different part of the shoulder. So even though it's all shoulder pain, right. One is soft tissue,
right,
and then one is the deep cartilage and hard tissue.
And interestingly, they feel the same. Their pain's in the same location.
Yeah.
They point to the same area. Their function, their range of motion may be a little bit different depending on how severe it is, but they often, without having seen an x-ray, I wouldn't know the difference between the two until we really actually see imaging.
Okay. So it's not as if you can hear the symptoms and go through exam and say, that's a rotator cuff tendonitis that needs therapy or injections versus that's shoulder arthritis that needs a replacement.
Correct. Yeah.
You need the imaging.
Right.
And there's so a physical therapist can't do it or an exam can't do it, you need the imaging.
Yeah, you at least need an x-ray. You know, an x-ray can tell us very well if somebody's arthritic. Mm-hmm. And if they're arthritic, that's sort of a clear answer. If they're not arthritic, then that's often when we start thinking about rotator cuff related issues.
Okay. I've seen such a transformation in shoulder replacements since the 90s. You know, and why wouldn't we? Because that was over 20 years ago. Back then, shoulder replacements, afterwards, patients, maybe they could lift their arms a little bit. But nowadays, I'm seeing patients get back to playing tennis.
Yeah.
It's what has happened in the past 5 to 10 years in shoulder replacement, and what does that mean for patients and their recovery and ultimate function?
I think several things have happened. I think probably the most important of which is the fact that there are a lot more shoulder replacements being done, and as a result, we've become much better at doing what we do. If you do something more frequently, the outcomes are going to be better. We know that from heart surgery, hip and knee replacements. Yes. Something that's done frequently is going to do better. we're going to do better at it. So that's part of it. The other part is our parts have gotten better.
Mm-hmm.
The technology's gotten better.
Mm-hmm.
And the surgeons have gotten better at actually putting in those parts, at managing the soft tissues,
Mm-hmm.
and trying to restore the best function that we can.
Okay, so more being done, and then that turns into a virtuous circle of experience, better results, better technique. Tell me about the technology side. Is it better technology means the shoulder can do more, the shoulder lasts longer, or the shoulder feels more natural?
Yeah, part of it is the parts themselves truly are better. The parts last longer than they did previously. Any artificial joint still has a timestamp on it. There's a point at which it will wear out, but they're lasting longer than they did in previous decades. But a big part of the technology is sort of advancing how we actually do the surgery. Rather than opening the shoulder, looking at it and trying to figure out where we need to put the socket, where we need to put the ball, we're doing a lot of planning ahead of time, and we're doing three-dimensional planning, essentially like a flight simulation of the surgery.
Sure.
Before we do the surgery.
Yeah.
And now we can even order guides that help us put in those parts according to the plan that we've already made. Yeah. So we have this spelled out plan, even the size of the parts that we need to put in before we ever walk into the operating room. Mm-hmm. And the surgery is essentially executing the plan that we already decided upon.
That's great. That's exactly what we're doing on the lower half of the body.
Yep.
In hip and knee replacement, and it's made all the difference in the world. Taking the extra time to plan, taking that extra hour ahead of time to plan means all the difference for years and decades for that patient.
Absolutely.
Down the road.
Yeah.
If we think about the patient who gets a shoulder replacement nowadays, so the rotator cuff is intact, but the shoulder is arthritic, and maybe they're older or late middle age, 60s, they like to play tennis. What would you let that patient know he might be able to expect once his shoulder is replaced? What limitations would he have, and what type of potential could he return to?
Yeah, the person that you just described, the person who has an intact rotator cuff and has an arthritic joint, the cartilage is worn down, we do the conventional or the standard shoulder replacement. The ball gets replaced, the socket gets replaced, and the soft tissues are essentially the same when you leave as they were when you came in. That person gets excellent pain relief, and I would say 80 to 90% of those people would tell me they're normal, or at least near normal, when they're a year down the road. A lot of them get back to overhead sports if they want to. Sometimes we have people who are young enough that are doing heavy weightlifting, and we need to tell them to put the brakes on a little bit because it can wear out the parts if you beat it up that heavily. Mm-hmm. But many of those people, I think, are getting back to everything that they want to do.
These are the questions that often I get asked, just because these patients want more than just pain relief. They want to be able to return to the active life they once led. And for a lot of patients, that means they want to get to be yoga, and they want to be able to do presses and downward dog. Would they be able to do that? Or would they have that restriction?
I would say that most of them could. After a standard shoulder replacement, most people can get back to doing things like that. Weight bearing, the flexibility of it. Not everybody can. Interestingly, the younger people often are the ones that maybe feel the limitations, meaning if we're doing a shoulder replacement in somebody exceptionally young, in their 40s, maybe 50s, I think the expectations might exceed what we can actually deliver for them. People in their 60s, 70s, I would say almost invariably say, I do everything I want to do.
Right. And those are patients who over time have voluntarily restricted themselves from using their arms. So they're doing this, they can barely get their arm up. But
they can still raise their arm. They can still, reach overhead like this.
Afterwards.
I mean, you would almost not even know that it was replaced if you
I've noticed that. When I see patients on exam and they raise their hands and they tell me they've had their shoulder replaced, I'm amazed, because I used to say, this used to be the shoulder replacement side.
Yeah.
And now, tell me about sports. A lot of our patients like to play tennis or a form of that called pickleball. Do you think that would be reasonable for them to return to with a successful result?
Absolutely. I see no harm in doing that. I think a lot of people can do it. I think it's actually probably good for them to do it.
Yeah.
Good for their shoulder, good for their overall health, of course. So I think a lot of people can do that, and they should.
I think the key thing about these results is that it's really dependent on finding expertise. So I tried to do shoulder replacements. I found the anatomy too disorienting for me. I just don't do enough of them. What advice would you give to patients who are dealing with an arthritic shoulder so that they might get the best possible outcome? Like among the world of shoulder surgeons.
I would tell you the most important thing to find is somebody who does a lot of shoulder replacements. It sounds simple enough. Finding somebody who does a lot of hip and knee replacements like yourself, there's a lot of people who do that. Some more than others, but there's a lot of people who do that. Shoulder replacements have grown tremendously in volume, but they are nowhere near the number being done every year as hip and knee replacements. So what we have seen, and this was true 30 years ago, it was true 15 years ago, and it's still true now, the majority of shoulder replacements are put in by surgeons who do less than 5 or 10 a year. That's a really stark number.
5 to 10 a year.
Yeah.
Okay.
And that's the majority of shoulder replacements being done. So what you want to find is somebody who specializes in shoulder surgery, in shoulder replacements in particular, who's doing a pretty high volume of them. It's pretty rare to find somebody who's doing 500, 700 shoulder replacements. We see that in hip and knees.
Sure.
There just aren't enough shoulders that need to be done. If you do over 25 a year, over 50 a year, that already puts you in the top 25 to 10%, 10 to 25% of shoulder surgeons in terms of volume.
So that might be a good baseline criteria for patients looking at such a big deal like a shoulder replacement.
Right.
You want it who does more than one every other month.
Correct.
So
Absolutely.
25 to 50 a year.
25 to 50 a year puts them into the highest volume of shoulder surgeons in the United States.
Let's go back to the other group. You said there was a group that had intact soft tissue, intact rotator cuff, but they were arthritic at the glenohumeral joint at the shoulder.
Okay.
Tell me about the other group that's always had difficulty. It's the one that was rotator cuff insufficient or deficient. How do you manage them? There was no answer back in the 90s when I trained on shoulders.
Right. Yeah, that person wears down the exact opposite way. The tendon goes first. When it's a moderate sized tear, we repair those, and most people do very well with that, but there's certainly people whose repairs fail, or whose tears are so large that they simply cannot be reattached.
Mm-hmm.
And in the 90s and before, there were very few options. We might be able to do a partial replacement and give them pain relief, but we could never restore their ability to raise their arm. They would come into surgery like this, and they would come out like this.
They'd be
and
more
hopefully
comfortable.
less pain.
Yeah, less pain, but no significant improvement in function.
Right.
Okay, that
And-
was then.
And so for probably 50 years, maybe even more, surgeons tried to invent replacements that could actually restore the function, change the mechanics of how the shoulder works, so that it didn't rely on the rotator cuff. The other muscles could make the shoulder raise. And finally, that really occurred in about the 80s in Europe, in France, and came to the United States in November of 2003. And since then, there's been an explosion of what's called the reverse shoulder replacement. That now, for the last 5 years, is actually more commonly done than the standard shoulder replacement. And what that does is it gives you the same pain relief of any other joint replacement, gives you excellent pain relief, but it takes that person who could only raise their arm like this, and after surgery, 6 months, 12 months later, when they're fully recovered, can get back to here. Overhead activity, not back to normal activity, but overhead activity, ability to turn their arm, reach behind their back, do the things that they literally couldn't do, and were extremely debilitating for them.
Yeah, you got to help me understand the nomenclature or the wording, because I know there's total shoulder.
Yeah.
Why is it called a reverse
Yeah.
total shoulder?
So the standard replacement and just our normal shoulders, the ball is on the arm. So it's on the top of the
humeral
arm,
of the arm
on
side.
the humerus.
Yeah.
And the socket is over here.
Right.
So the reverse is flipped. So the ball is now on on the old socket, and the socket is now on top of the arm where the ball used to be. And because of that change in the mechanics, the rest of the muscles, like your deltoid, which is almost never affected by any sort of tearing or wear and tear over the years, your other muscles that can function around the shoulder then have enough power and can pull against the shoulder to actually raise the arm. And that's how the reverse replacement really works.
I see. So it's still a ball and socket. It's
Still
just
a
that
ball
the
and
position of the ball
yeah.
and socket have flipped.
Exactly. Still a joint replacement, so it's the pain relief is really from replacing the worn down parts, metal and plastic parts, just like every other joint replacement we do. But the functional change is because we're changing the mechanics.
And we have to clearly differentiate outcomes between the total shoulder versus the reverse shoulder, because they're coming in with a very different level of function.
Right.
And so we would expect them to have a different level of functional result.
That's right. And even more importantly, the person who's getting a reverse replacement, the reason they're having it done impacts their final outcome probably more than anything else. So the person who's having it done for rotator cuff repair that is end stage, it's not repairable, those people probably get the best function out of that reverse replacement. They get, good overhead activity, pretty good rotational function. If you're having it done for a really bad fracture that we have decided is not able to be put back together, those people get good pain relief, a little bit more modest function. Instead of all the way up here, they're ending up about here. And the person who's having it done in a truly salvage situation, like a previously failed joint replacement, they still get good pain relief. They still get improvements, but nowhere near the person who's having a virgin shoulder surgery. So that person might at least be able to get to here, maybe a little more, but it's not quite the same, not comparing apples to apples.
Sure. And then the third category, I see this on our surgical board or our surgery schedule more often, are those that come in with a pretty significant trauma to the shoulder. So the shoulder joint or the humeral head is just broken into many, many parts.
Right.
And instead of being fixed where the bone's put back together with plates and screws, a new shoulder is going in.
Yeah.
How do those people do?
Those people get good pain relief. They have very predictable function. That's the real benefit of doing the reverse shoulder replacement in the setting of a bad fracture. When we would fix those fractures previously, especially in older individuals, those are very common in people over the age of 60. The bone is very soft, which is why it breaks in the first place with just a simple fall. The failure rate was unacceptable. The failure rate honestly was 10 or 20%, almost at a minimum. People who healed would get good function, but the failure rate was just so large. The reverse replacement gives us much more predictable outcomes. Rather than these people who do very well and these people who catastrophically fail, we're getting pretty consistent functions of people at least able to reach over their head, good pain relief, and a satisfactory outcome with what otherwise was sort of a roll of the dice trying to get the shoulder to heal with fragile bones.
Right. Let's just back up and go to just some of the basics of shoulder replacement now. How long does the procedure take? How long does the patient stay in the hospital? What does the blood loss look like? What does recovery look like, and for how long?
Yeah. A couple things. So surgery is maybe an hour and a half. People, I'd say probably over half, if not 2/3 of people are going home the same day. You go home in a sling, so as long as you're medically safe to go home, that's really the key. There's no rehab that you need to do the day of surgery or the next day. So as long as it's safe to go home, that's when the person can go home. And they're truly going home, not to skilled nursing facilities, not to rehab centers. They go home with their family and they stay in their own house. Usually start some gentle stretching in a couple weeks. The pain recovery and the functional recovery are definitely separate conversations, because the functional recovery, we have to let some of the things heal. It's not like a hip or knee where we want them to go as quick as possible. We want them to settle in a little bit. And so intentionally, it's probably around a 6-month recovery before people reach their new normal. We don't really even want it to go faster than that. Now, the pain recovery is very different. I'd say people who come in with end-stage arthritis, these massive rotator cuff tears, within the first few weeks often tell me they have less pain than they did before surgery. So the pain relief comes much sooner. Maxing out the function, getting back overhead function, good strength takes upwards of 6 months, sometimes 12 months for some. But they're very different conversations.
Sure. I often get asked, I'm sure you do in your office, about returning to normal life or their obligations, like when can they get back to driving, especially if they're right-handed? When can they use a computer? And when could they go back to work after a shoulder replacement?
Essentially, immediately afterwards, we allow them to use their elbow and their hands so they can feed themselves right away, they can write, they can type, but they're not raising the arm right away. So you do have some limitations early on.
Okay, so they can still use the hand,
correct,
but the shoulder is just protected in a sling.
Exactly. The arm stays down here for the first 6 weeks typically. So there's no driving for the first 6 weeks. That could be one of the more challenging things early on. The returning to work, if somebody has a computer or a desk type job, I would say a week or two. Just make sure you're comfortable before you can go back, but you can start to do it immediately. Getting back to more physical work certainly depends on how physical it is and what the demands of that job are. So it might be a few months before people are returning to more physically demanding jobs.
Got it.